So now we've got our first dose distribution, we're going to have a look at optimizing the plan. So we're going to have a look at changing the field size, changing the wedges and changing the weighting to see what all of those do. So in the clinical environment you would do a combination of these all at the same time, and with experience clearly you can do that, but what we're going to do is have a look at them step by step to see what each of them do, and then once you've got some experience and practice of doing that, you can do them in combination with each other. So the first thing we're going to have a look at is the field size, and if we remember, the field size controls in this technique our dose distribution of the high dose region. So we're interested in the 95 to 107 isodoses, aren't we? That's our dose gradient across the PTV, and by looking in our three views we can see that straight away, if we look here in our coronal view, we can see the PTV on that point there, and the 95, this blue isodose, isn't quite covering. And if we look here in the sagittal, again that's really clear, the PTV is up here and the 95% isodose is here. So what we want to do is scroll through and review the plan slice by slice. So a slice like this, in terms of this minimum coverage of the 95% isodose, that's the only thing we're going to think about for the moment, is we can see here that actually that's not too bad. So we can see it's clipping the PTV a tiny bit down there, but that's not something we're too concerned with. And actually we would ideally want to reduce the gap from there to there, and the gap from there to there, okay, and then the gap from there to there. So we want this blue isodose, this 95, to conform as tightly as possible around this PTV, which is the red. Now we've got this three field technique, so we're always going to have a square in the middle. So we're not going to be able to conform around these corners using this technique, but what we are going to do is be able to move the square tighter, or the rectangle smaller or bigger. So if we think about this slice just to start off as a demonstration, we can see that, as we said, it's too wide there and too wide there, so laterally. So that's the thing I'm going to sort out now. So we can do that by changing the field size, and what we're going to do is, if we move the field size in, so make the field size smaller, then this high dose region is going to move with that 95% isodose. So what we need to do is find out where we are on the patient, and Eclipse has got quite a nice tool for this. So as we scroll up and down, we can see, if we look in this beam's eye view, that the grey line moves with it, and that tells us where we are on the patient. So if we go back to this slide here, the field that's going to impact the dose distribution there and there is going to be anterior field. So if we look here, if I turn the other fields off, so we can turn fields off by unticking them there, we can see that the gold colour there is the field edge, the MLCs, and if we were to move those in, then the 95% isodose would move with that. So if we just look around the few slices laterally of that point, we can see the dose distribution is quite loose or baggy around that point. And if we look here in our beam's eye view, we can see that's the MLCs here and here. So what we're going to do, let's make this bigger just to make life a bit easier. Click on the MLC icon there, and then we're going to make our MLCs a bit tighter. So we can make it tighter there, tighter there, tighter there, tighter there, and tighter there. So you're going to have to just excuse this this error here really. So I'm doing this on a remote connection, and we've just got a bit of an artifact there on the imaging, so that won't appear on yours. So what I'm going to do now is calculate that, so we could hit F5 or hit the button there, and it's just going to recalculate that beam, which shouldn't take too long. And then if we go back to this slice here, we can see that that's moved in there, so that's nicely just about to clip the PTV, and maybe we could move that in a tiny bit more. So by moving that field bigger and smaller, we're going to move the isodose bigger and smaller as well laterally. It's a little bit baggy here, so again we could pick up one of the lateral fields, left or right, would both do the same thing, or what we would probably do is move them both a tiny bit. So we want to move the field size smaller in this region here. So if we go back to our beam's eye view, pick a left field, and we know that that's anterior, so we can see our little man there, and we can see the anatomy up there to tell us that's ant, and the big A as well. So the lines there, so that's these MLCs here. So we could move again those MLCs in that region there, recalculate, and that would cause the isodosis to pull tighter there. One last thing to mention about field size. Typically, if we set the field size to 0.5 supernymph, as we have done, then we're typically going to underdose at either end superinf. So we can see there that this is covered by the 90% isodose, but it's not covered by the 95. So we need to open up the field size there. And if we scroll to the other end, and we can see that once again it's covering with the 90% isodose just about, but not with the 95. So what we would do with that, again, we're superior slice now. All of the fields 1, 2 and 3 are irradiating in this top region here. So we can see that this is the part that's been overdosed here. So if we look at the ant, we can see that is the lateral and the other lateral. So by moving one or any of those fields, making the field size bigger in any of those regions would increase coverage. And what we need to do with that plan will be to move all of them, maybe, I don't know, 5 mils, something like that. So once again, it is quite an iterative process. So we would change it and then calculate, see if that's done the job. If it's not, then change it again and recalculate.